Yeah, please proceed, madam.
Yes, sir. Hello, everyone. Welcome to Tawheed Foundation for Allied Healthcare Sciences at Bangalore. So, today's topic is mycology part 2. In last class, we studied about what is mycology, its definition, types of pathogens, that is true and opportunistic pathogens, fungal form, that is yeast, molds, and dimorphic fungi, its classification, that is zygomycota, escomycota, basidiomycota, and deuteromycota, and clinical types of mycosis, that is superficial or cutaneous, subcutaneous, systemic, and last is opportunistic. Last, we studied lab diagnosis. So, in this class, we'll study in detail um, all the diseases caused by fungal infection. So, introduction, we'll start with introduction. Mycosis refers to infection caused by fungal agents. Fungi are nothing but eukaryotes with cell wall that grow as multicellular filaments, that is mold, or individual cells alone or in chains, which is yeast. Molds consist of thread-like filaments called hyphae. Hyphae produce round cells called conidia that easily become airborne, disseminating the fungus. So many pathogenic fungi are dimorphic in nature, which forms hyphae at ambient temperatures, but yeast at body temperature, for example, blastomyces, histoplasma, etc. Mycosis are of four major types. That is, first is superficial and cutaneous mycosis, second subcutaneous mycosis, third is endemic mycosis, fourth is opportunistic mycosis. So, deep mycosis include subcutaneous, endemic, which is caused by dimorphic fungi and life-threatening systemic illness, and opportunistic mycosis seen in immunocompromised or prosthesized individuals. Methods of specimen collection for diagnosing mycosis. The diagnosis of mycotic infection is contingent upon proper selection, collection, and transport of appropriate clinical sample. Specimen volume must be adequate to perform all the tests. In case of inadequate sample, at least two swabs to be taken for microscopy and culture. If material is inadequate, it can be collected with sterile swab, which stick moistened with NS. Skin scraping and hair should be transported in dry containers or envelope. It is essential for specimen to be collected aseptically from the deeper part of the wound, or else superficial contaminating fungi or bacteria will overgrow and suppress its pathogenic fungi. Rapid transport of specimen in less than 2 hours ensures optimum recovery of fungi. Scanty material or dry swabs was not acceptable. The saline for injection solution, which may contain antimicrobial substance, should be avoided while collecting biopsy tissue for HPE or grains from sinus tract. Tissue specimen to be sent in saline and not in formal saline for culture test. Transport of specimen. Specimen must be transported and processed within 2 hours of collection, preferably so that it will not be contaminated. To minimize the overgrowth of commensal, in case of specimen taken from nose, oral mucosa, or nail, penicillium that around 200 mu per ml, streptomycin or chloramphenicol added as an antibiotic may to the specimen to avoid contamination. In case of delay of specimen can be stored under refrigeration at 4 degrees Celsius but not more than 24 hours of collection. Blood and CSF are stored at 37 degrees Celsius. Dermatological specimens at 15 to 30 degrees Celsius. Specimen like sublingual debris, hair, skin, scraping can be directly inoculated onto the appropriate media immediately after collection for the optimum recovery of the fungi. So from here we'll start in detail, that is subcutaneous mycosis. It includes mycetoma. Etiological agent may be bacterial or fungal. Discussion will be restricted to fungal mycetoma, chlorom, chromoblastomycosis, pheophoma, mycosis, sporotrichosis, lobomycosis, and last is rhinosporidiosis. We'll start with mycetoma. So, mycetoma is a clinical syndrome of localized indolent deforming swollen lesions and sinuses involving cutaneous and subcutaneous tissues, fascia, and bone, usually occurring on the foot or hand. Etiological agent can be bacteria or fungi. So mycetoma usually more common in men, that is 3:1 to 5:1, than in women. Usually results from trauma or puncture wounds to feet, legs, arms, and hands. Usually it occurs on the feet. So it starts out as tumor-like to subcutaneous swelling, ruptures near the surface, infects deeper tissues, including subcutaneous tissues and ligaments, that is, tendons, muscles, and bones are usually spared. Small particles or grains leak out of the lesions. These represent the yellowish microcolonies. Mycetoma, it is a lesion, seldom heals spontaneously. Disease is chronic and may continue for up to 40 to 50 years. Ketoconazole appears to be ineffective in clinical trials. Intravenous miconazole, that is 9 mg per kg of body weight, sometimes higher doses, shows promising results. Surgery and removal of tumor. If small, it is encapsulated. If larger, ampulation may be required. Combining miconazole and surgery may provide useful in effectively treating this disease. You can see in this diagram how this fungal infection is caused on feet, mainly in feet and on back. Eumycotic mycetoma granules is showed here in this image, pink colored in PAS stain. This pink colored. In last class, we studied about this pink colored stain. Chromboblastomycosis. It is a disease, one of hyperplasia characterized by the formation of rough, warty cutaneous nodules which raised 1 to 3 centimeter above the skin surface. The roughened, irregular, pedunculated vegetation often resembles the cauliflower. This disease is caused by Fonseca pedrosoi and Phyllophora verrucosa, identical to Cadophora americana, which causes buoying of lumber, both of which are dematicious fungi, that is darkly pigmented. Occurs rarely in animals such as horses, cats, dogs, and frogs. It is soil inhibiting fungi. It is also susceptible enhanced by going barefoot or wearing sandals, found almost exclusively in laborers, enters hand or feet after trauma. It is found primarily in the tropics or subtropics. Dull red or violet color on skin may resemble a ringworm lesions, develops into verrucous lesions. Pruritus, itchiness, and papules may be developed. So fungus gets under the skin, produces bumps. You can see in this image, bumps may block lymphatic system and cause elephantiasis, that is swollen of legs. Sometimes bacterial infection may enter and cause a secondary infection. Rarely, this fungal spreads to other areas of the subcutaneous tissues, potentially spread to brain, which is life-threatening in that case. Identification, you can take biopsy tissues, look at the skin for fungus, hematoxylin stain, look for fungal cells scattering among skin cells. Attempt to culture fungals from biopsy tissue must always take place to identify the etiological or causative agent. Colonies of fungi are dark or blackish. Two species implicated in this mycosis, each may produce several spore types. First, this is Fonseca Yeah, pedroici. So these cladosporium type and rhinoclady type of conidiation. Second is Fiella lophora verrucua. These called as flowers in vase conidiation. So fungi found growing on plant debris, wood and soil. Treatment usually not fatal or necessarily painful. Unslightly disease, it is not really good cure. So it shows promise mixed given orally or on skin mixed with dimethyl sulfoxide, that is DMSO, to deliver drugs. Surgical excision useful in early stages of disease. Application of heat to infect site has been reported to effect a cure of the disease after 6 months of treatment. So itraconazole shows promise in clinical trials of this chromboplastomycosis. Third is pheophymomycosis, subcutaneous or brain abscess caused by dematicious fungi. Its affected area is thighs, legs, feet, arms, and brain, that is cerebral. Etiology: dematicious imperfect mole fungi, mainly Cladosporium, Exophilia, Vangelia, Cladophila. All these are the etiology for fear of pheohyphomycosis. Neutrophilic fungi, cerebral PHM, naturally in woody plant, woods, agricultural soil. Its laboratory diagnosis, you can tell specimen include pus, biopsy tissue, direct microscopic examination include KOH and smear, brown septi hyphae, culture on SDA, that is sebrodextrose agar, and it's very slow growing black or gray color colonies. You can see here the example of pheohyphomycosis, Fiella, bipolaris, and exophilia. These are the examples. Sporotrichosis. So, lymphocutaneous and subcutaneous granulomatous lesions separate, ulcerate. These lesions are nodules, all ulcers in local lymphatics. Its affected site is extremities in joints. In agriculture communities, its etiology is dimorphic, imperfect fungus in trees, shrubs, decaying vegetation. Sporothrix, it is a yeast in human tissue, and at 37 degrees Celsius in culture, it will grow. So its laboratory diagnosis: specimen, you can take biopsy tissue, ulcerative material, direct microscopy smear, finger yeast like cells or cigar shaped. Some are oval. Culture on SDA media at room temperature to grow molds, on blood at 37 degrees Celsius to grow yeast. This is the example of sporotrichosis. Fourth is lobomycosis. Lobomycosis, it is a cutaneous, subcutaneous fungal infection. Its lesion is keloidal, verrucoid, nodular. Sites, you can tell face, ear, arms, and legs. It will infect. Chronic and localized disease. Etiology, you can tell Lacazia loboi, which means Loboa loboi, obligatory parasitic fungus infection. It will not grow in culture like SDS, Sabrodextrose agar media, or tissue culture. Laboratory diagnosis: the specimen is biopsy tissue. Direct microscopy will show chains of cells. Culture of specimens will be negative. Its management: surgical excision of lesion will be done. Rhinosporidiasis. Rhinosporidiasis is a clinical mucocutaneous fungal infection. Sites is nasal, oral, conjunctiva, that is eye. Lesions: polyps, papillomas, warts like lesions you can see. more seen in communities near swamps. Its etiology is Rhinosporidium sebri. It is an obligatory parasitic fungal infection. It is believed to be Chytridiomycetes, and it does not grow on artificial media but has been grown in tissue cultures. Laboratory diagnosis specimens include biopsy tissues, direct microscopy, stain sections, or smears. KOH will show spherules with endospores. Culture on Cerebrodextrous agar will be negative. Its management, cryosurgical excision of region relapse is very common. This is a microscopic feature of rhinosporidiosis. Endemic mycosis. In this, there is four mycosis: coccidioidomycosis, blastomycosis, paracoccidioidomycosis, and last is histomycosis. We'll study each of them in detail. First is coccidioidomycosis. It is a disease. Coccidioides immitis causes coccidiomycosis. Its properties is it is dimorphic fungus that exists as mold and as a spherule in tissue. You can see in this image. Its transmission and epidemiology. The fungus is endemic in arid regions of the southwestern and United States and Latin America. It is very common. People who live in central and southern California, Arizona, New Mexico, western Texas, and northern Mexico, a geographic region called the lower Sonoran life zone, are often infected with this coccidiomycosis. In soil, it forms hyphae with alternating arthrospores and empty cells. Arthrospores are very light and are carried by the wind. They can be inhaled and infected the lungs. Its pathogenesis in the lungs, arthrospores forms spherules that are large, have a thick, doubly refractive wall, and are filled with endospores. Upon rupture of the wall and are filled with endospores are released and differentiate to form new spherules. The organism can spread within a person and direct extension or via the bloodstream. Granulomatous lesions can occur in virtually any organ but are found primarily in bones and the central nervous system, that is meningitis. Dissemination from the lungs to other organs occurs in people who have a defect in cell-mediated immunity. Most people who are infected with this C, that is coccidiomycosis immitis, who are infected develop a cell-mediated immune response that restricts the growth of the organism. One way to determine whether a person has produced adequate cell-mediated immunity to the organism is to do a skin test. In general, a person who has a positive skin test reaction has developed sufficient immunity to prevent disseminated disease from occurring. If later time a person's cellular immunity is suppressed by drugs or disease, disseminated disease can also occur. So, infection of the lung is often asymptomatic and is evident only by a positive skin test and the presence of antibodies. Some infected persons have an influenza-like illness with fever and cough. About 50% have changes in the lungs as seen on chest X-ray. 10% develop erythema nodum or arthralgiasis. This syndrome is called valley fever or desert rheumatism. It tends to subside spontaneously. Disseminated disease can occur in almost any organ. The meningitis, bone, and skin are very important site. So the overall incidence of dissemination in person infected with C. hepatitis is 1%, although the incidence in Filipinois and African Americans is 10 times higher. Women in the third trimester of pregnancy also have markedly increased incidence of dissemination. Erythema nodosum manifests as red tender nodules on extensor surfaces such as the shines. It is delayed hypersensitivity response to fungal antigens, and thus it is an indicator of a good prognosis. Clinical findings of coccidioidomycosis: there are no organism in these lesions. They are not a sign of disseminated diseases. It is not specific for coccidioidomycosis. It occurs in other granulomycosis disease, that is histoplasmosis, tuberculosis, and leprosy. In infected person, skin test with fungal extract cause at least 5 mm in duration 48 hours after injection. So skin tests become positive within 2 to 4 weeks of infection and remain so for years but are often negative in patients with disseminated diseases. Laboratory diagnosis: in tissue specimens, sporidius are seen microscopically. Cultures on Sabrodextrus agar incubated at 25 degrees Celsius shows hyphae with arthrospores. In serologic tests, IgM and IgG antibodies precipitates appears within 2 to 4 weeks of infection and then decline in subsequent months. Complement fixing antibodies occurs at low titer initially, but the titer rises greatly if dissemination occurs. Treatment and prevention of coccidioidomycosis: so no treatment is needed in asymptomatic or mild primary infection. Amphotericin B, fungizone, or itraconazole is used for persisting lung lesions or disseminated disease. Ketoconazole is also effective in lung disease. Fluconazole is the drug of choice for meningitis. Itratrical amphotericin B may require and may induce remissions, but long-term results are often poor. There are no means of prevention except avoiding travel to endemic areas, which causes coccidioidomycosis. Blastomycosis. Blastomycosis dermatitis cause blastomycosis known as North America blastomycosis. B. dermatitis is a dimorphic fungus that exists as a mold in soil and a yeast in tissue. The yeast is round with a doubly refractive wall and a single broad-based bud. You can see in this image. You should note that this organism forms a broad-based bud, whereas Cryptococcus neoforms is a yeast that forms a narrow-based bud. This is the difference between these two. Transmission and epidemiology of blastomyces. This fungus is endemic primarily in eastern North America, especially in the regions bordering and the Great Lakes regions. Less commonly, blastomycosis has also occurred in Central and South America, Africa, and the Middle East. It grows in moist soil rich in organic material, forming hyphae-like structures with small pear-shaped conidia. Inhalation of this conidia causes human infection. Pathogenesis: infection occurs mainly via the respiratory tract. Asymptomatic or mild cases are rarely recognized. Dissemination may result in ulcered granulomas of skin, bones, and other substances. Blastomycosis is endemic in Central and South America, especially in the regions bordering and the Great Lakes regions.
Hello. 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 नहीं डिस्कनेक्ट हो गया. Thinking.
Am I audible, sir?
Yeah, madam, please.
Yes, sir. Due to network issue, here rain is going on, so Wi-Fi is disconnected.
Yeah,
We'll
yeah.
continue with
No
blastomycosis.
issue, no issue.
So, all right, sir. For laboratory diagnosis in tissue, biopsy specimen, thick-walled yeast cells with single broad-based buds are seen microscopically. Hyphae with small pear-shaped conidia are visible on culture. The skin test lacks specificity and has little value. Serological tests have little value compared to other tests. So tissue sections, this is a diagrammatic representation of tissue sections showing large, broad-based unipolar budding yeast-like cells. Treatment and prevention of blastomycosis. Itraconazole is the drug of choice for most patients. Amphotericin B should be used to treat severe diseases. Surgical excision, it can be helpful. There are no means of other prevention for blastomycosis. Fourth is paracoccidioides. So paracoccidioides brasiliensis causes a paracoccidiomycosis, also known as South American blastomycosis. It is a dimorphic fungi that exists as a mold in soil and as a yeast in tissue. The yeast is thick-walled with multiple buds in contrast to B. dermatitis, which has a single bud. So the spores are inhaled and early lesions occurs in the lungs. Asymptomatic infection is very common. Alternatively, oral mucous membrane lesions, lymph node enlargement, and sometimes dissemination to many organs develop this paracoccidioides. Its laboratory diagnosis include pus or tissues, yeast cells with multiple buds are seen microscopically. A specimen cultured for 2 to 4 weeks grow typical organisms. Skin tests are rarely helpful for this disease. Serological testing shows that when significant antibody titers by immunodiffusion or complement fixation are found, active disease is present. Treatment for this paracoccidioides, the drug of choice is itraconazole taken orally for several months. And apart from itraconazole, there are no means of prevention for this disease. You can see multiple narrow base budding yeast cell stirring wheels of P. brasiliensis causing this paracoccidioids. Histoplasmosis. Histoplasmosis capsulatum causes histoplasmosis caused by histoplasma. H. capsulatum is a dimorphic fungus that exists as a mold in soil and as a yeast in tissue. It forms two types of asexual spores. First is tuberculative macroconidia, second is microconidia. So with typical thick walls and finger-like projections that are important in laboratory identification is for tuberculative macroconidia, and which are smaller, thin, smooth-walled spores. If inhaled, transmit the infection is caused by microconidia. So in this image, you can see macroconidia and microconidia. Thick one is macroconidia, whereas thin one is microconidia. Transmission and epidemiology. This fungus occurs in many parts of the world. In US, it is endemic in central and eastern states, especially near rear valleys. It grows in soil, particularly if the soil is heavily contaminated with bird droppings, especially from starlings. Although the birds are not infected, bats can be infected and can excrete the organism in their feces. Transmission In areas of endemic infection, excavation of soil during construction or exploration of bat-infested caves has resulted in a significant number of infected individuals. In several tropical African countries, this histoplasmosis is caused by Histoplasma duboisi. This clinical picture is different from that caused by H. capsulatum. A description of these differences between Africa histoplasmosis and that seen in US is beyond the scope of this. So its pathogenesis, while inhaled spores are engulfed by macrophages and develop into yeast forms in tissues, it occurs as an oval budding yeast inside macrophages. The yeast survive within the phagolysosome of the macrophages by producing alkaline substances such as bicarbonate and ammonia that raise the pH and thereby inactivate the degradative enzymes of these. The organisms spread widely throughout the body, especially to the liver and spleen, but most infections remain asymptomatic and the small grandomatous foci heal by calcification. So, with intense exposure, pneumonia may be clinically manifest. Severe disseminated histoplasmosis develop in a small minority of infected person, especially infant can cause this histoplasmosis, and as well as in AIDS patient. In AIDS patient, ulcerated lesions on the tongue are typical of disseminated histoplasmosis. In immunocompetent patients can occur this histoplasmosis. Summary: blastomycosis, dermatitis, its infection is caused by blastomycosis. Dissemination is skin and bone, later nervous system and visceral organs. Drug of choice include amphotericin B and itraconazole. Coccidioides immitis caused by infection coccidioidomycosis. Dissemination is through skin lesions, bones, joints, subcutaneous tissues, and visceral organs. Drug of choice include amphotericin B. Paracoccidioides brasiliensis infection is caused paracoccidiomycosis. Dissemination is through oral nasal mucosa, later spleen, liver, intestine, and skin. Drug of choice include amphotericin B, sulfas, or azoles. Histoplasma capsulatum caused infection histoplasmosis. Dissemination is through acute pneumonia, that is called as cave disease, chronic pneumonia, smoker, disseminated immunocompromised, and last is primary cutaneous. Drug of choice include amphotericin B. For laboratory diagnosis of histoplasma capsulatum, in tissue biopsy specimens or bone marrow include several oval yeast macrophages are seen microscopically. Opportunistic mycosis. So, opportunistic mycosis are fungal infections that do not normally cause disease in healthy people. It do not cause disease in people with weakened immune defenses, that is immunocompromised patient. Weakened immune functions may occur due to inherited immunodeficiency disease, which include drugs that suppresses the immune system. In cancer, chemotherapy, corticosteroids, drugs to prevent organ transplant rejection, and in radiation therapy, infections include HIV, cancer, diabetes, advanced stage, and malnutrition. So, classification of this opportunistic mycosis is of four types. First include candidiasis, second aspergillosis, third is cryptococcosis, and last is mucormycosis. These are the four classification of opportunistic mycosis. Candidiasis. So candidiasis is caused by Candida albicans, which is a member of the indigenous microbial flora of humans. It is found in the gastrointestinal tract, upper respiratory tract, buccal cavity, and vaginal tract. Growth is normally suppressed by other microorganism areas. Alteration of gastrointestinal tract flora by broad spectrum antibiotics or mucosal injury can lead to gastrointestinal tract infection. So candidiasis, it is a skin and mucous membrane are normally an effective barrier work, but damage by introduction of catheters or intravascular devices can permit candida to enter via bloodstream. In healthy individual, candida causes vaginitis and diaper rash in infants. Severe disseminated candidiasis most commonly occurs in neutropenic patients due to leukemia, chemotherapy, etc., and leads to candidiasis. Its pathogenesis, a single strain of candida can be successful as commensal and pathogen. Candida can shift between different phenotypes called phenotypic switching. First, it can form hypha, and if under favorable condition, it can convert into pseudohyphae. This phenotypic switching involves coordinated regulation of phase-specific genes. These variations exhibit altered colony morphology, cell shape, antigenicity, and virulence. Candida produce large number of functionally distinct adhesions. Adhesion is a virulence factor of Candida that contribute virulence. Adhesions include integrin-like projections, protein that binds to epithelial cells, several agglutination that bind to endothelial cells. Candida can produce enzymes like aspartyl proteinases, catalases. These enzymes can be produced while Candida albicans grow as biofilms, microbial communities of yeast plus filamentous form. Its pathogenicity, increased risk of Candida infection in neutrophilic patients or patients with NADPH oxidase. Filamentous form can escape from phagocytic damage. So yeast cell cause this candidiasis. Second is its lab diagnosis include tissue sections and pseudohyphae, chain of budding yeast cell. All forms may be present together is seen in this diagrammatic representation of AIDS patient causing candidiasis in mouth, which is also called as thrush. Aspergillosis. Aspergillus, it is the most common pathogenic species cause diseases in humans. Its entry of portal is through inhalation of conidia. Major risk factors include neutropenia and use of corticosteroids. So its pathogenesis, alveolar macrophages recognize aspergillus through TLR2 and lactin detectin ductin 1, activation of phagocytes to ingest and kill conidia. In immunosuppressed patients, conidia can germinate into hyphae, which invades tissue. TLR recognizes products of hyphae and release inflammatory cytokines. So these neutrophils come into action and oxidase damage of hyphae will occur. So virulence factor of aspergillus include adhesins, antioxidants, and toxins. Antioxidants include melanin, catalase, and toxin. It is a diagrammatic representation. Clinical findings, sinusitis, aspergillus asthma,
Hello,
colonizing.
madam.
Hello, can you hear me,
Madam,
sir?
I will join within 10 minutes because prayer time now.
Sure, sir, sure, sir.
Okay, thank you, madam.
So should I stop here, sir?
No, madam, we can continue. No issues.
I'll continue. All
Yeah,
right,
please.
sir. All right, sir. So, clinical findings, invasive aspergillosa in immunosuppressed hosts, it is widespread through hematogenous spreads, involves heart valves, brains, pulmonary invasive aspergillosis, which shows pneumonia. Lab diagnosis include it form fruiting bodies and hyaline separate hyphae branching at acute angle. So these are caused by aspergillosis. Cryptococcosis. It is a human disease caused by Cryptococcus neoformans and Cryptococcus gattii. Its risk factor is AIDS, leukemia, lymphoma, and immunosuppressed transplant individuals. So it is present in soil and blood dropping, and mode of transmission is inhalation. Its mode of transmission is through inhalation. Wait. Cryptococcosis, it is a human disease caused by Cryptococcus neoformans and Cryptococcus gattii. Its risk factor includes in patients of AIDS, leukemia, lymphoma, and immunosuppressed transplant individuals. It is present in soil and bird dropping, and mode of transmission is through inhalation. Cryptococcus gattii causes infection in otherwise normal individual. Its virulence factor is polysaccharide capsule, which prevent phagocytosis, melanin antioxidant property, cell wall integrity, and decrease phagocytosis. Enzymes include in cryptococcosis is phenol oxidase, cleaves fibronectin, and other basement membrane protein aids in tissue invasion. Clinical findings of cryptococcosis involves meningitis, cortical gray matter, and basal nuclei. In immunocompromised individuals, gelatinous masses of fungi grow in meninges. Skin involvement is second common method. Bone involvement may also occur. Lab diagnosis include CSF in tissue specimen. Last is Mucormycosis. Mucormycosis are widely distributed in nature. There's no harm to immunocompetent individuals, which causes mucormycosis. They infect immunosuppressed people, causing mucormycosis. Its causative agent is Mucorrhizopus and Cunningamella. Its modes of transmission is through ingestion. Inhaled spore causes infection in the sinuses and lungs. Macrophages provide initial defense by killing phagocytosis and non-oxidative sporangiospores. Its pathogenesis, iron promotes growth of mucormycosis It increases possibility of infection seen in diabetic patients due to increased free ions. Ketoacidosis induce poor affinity iron. So clinical finding of this mucormycosis in local tissue necrosis, it invades arterial walls and penetrates through the periobrittle tissue with and without cerebral infection. Lung involvement, it includes hemorrhage, pneumonia. Lab diagnosis in tissue specimen, non-septate hyphae will be seen in culture in cerebrodextrose plate, dense hairy colony will be visible. Summary, subcutaneous mycosis, example include mycetoma, chromoblastomycosis, porotrichosis. It is caused by traumatic implantation of fungi. Endemic mycosis, example is histoplasmosis, blastomycosis, and coccidiomycosis, and last is paracoccidiomycosis. It is acquired by inhalation of spores. Opportunistic mycosis, example include candidiasis, aspergillosis, cryptococcosis, and last is mucormycosis. It occurs in immunocompromised individuals, and it will not be present in healthy individuals generally because their immune system is strong compared to immunocompromised individuals. Additional topics covered in today's class is specimen collection and transport method, its diagnostic techniques and clinical features of and diagnostic hallmarks. Questions? For 3-mark questions, define subcutaneous mycosis with one example. Second, what are sclerotic bodies in chromoblastomycosis? Third, name 2 opportunistic fungal infection. First is candidiasis and second is aspergillus. So write about those 2 opportunistic fungal infection and why it is caused. Fourth, write the diagnostic method for cryptococcosis. Last is what is Rose Gardner's disease. For 5-mark question, describe the clinical features and diagnosis of mycetoma. Second is explain histoplasmosis with causative agent and diagnostic method. Third, describe mucormycosis in detail. Last is differentiate between chromoblastomycosis and pheohyphomycosis. So that's all for today's class. So we covered whole thing in mycology unit. These topics, subcutaneous mycosis is very important. In detail, everything should be covered. Mycetoma, chromoblastomycosis, pheohyphomycosis, porotrichosis, lobomycosis, and rhinosporidiosis. And this endemic mycosis, in this 4 subtopic is there: coccidiomycosis, blastomycosis, paracoccidiomycosis, and last is histoplasmosis. So we covered whole thing in mycology part 2. So that's
Very
all.
nicely you have spoken, madam.
Thank you,
Uh,
sir.
I think today mycology, I think you have completed. I think.
Topic is covered. Yes, sir.
Yeah, madam. Very nice, madam. Thank you so
Main
much,
in
madam.
mycology, sir, terminology is important.
Yeah,
Students should focus on that because it is very difficult to pronounce as well
yeah,
as spelling is also quite tricky.
yeah.
So
To memorize also,
yes,
because they have to write on that particular
yes, sir. If one
topic for
mistake,
examining.
their marks will be cut.
Yeah.
So yes, sir. All
Very
right.
nice, madam. Thank you. That too,
Thank
today
you,
is
sir.
Sunday. You have
Yes.
taken time and you have conducted
No
classes.
issues,
Very
sir.
nice.
All
Thank you.
right,
Thank
sir.
you so much, madam.
Only one topic is remaining for first year BSc MLT students.
Yeah.
That
So
is,
after
I guess,
that, I think
still.
we'll continue
Yeah.
with the second
Yes,
year.
sir. We'll continue that.
Yeah.
All right,
Thank you,
sir.
madam.
Thank you, sir.
Thank you
Thank
so much.